be a basic discussion, but if anything needed extra, you can ask at the end of session. So I will proceed with my talk. So liver is having a scavenger role, and it is one organ in the body which receives maximum insult during your entire lifetime. Even though you may not be taking alcohol or any other liver toxins, if you live here and you take the food and other things which is available here, your liver is actually getting damaged from so many sources, including the air fresheners, air pollution, personal care products, etc. So jaundice is one of the symptoms of liver disease. So I will come to jaundice bit late. So coming to the history of jaundice, even though the jaundice is described way back in Hippocrates era, the actual research in the jaundice started only in 20th century. And in 1921, only Vandenberg described the reaction to identify or you estimate the serum bilirubin. So after that, so many other scientists introduced the estimation of urobilinogen, quantitative method for assessing alkaline phosphatase and prothrombin time. So many things introduced, and only in 2000, the MEL score, which was commonly used for liver transplantation, was introduced in practice. So this was the icteric index, which was the earlier method for identifying jaundice in the serum. So they have 0, 1 plus, 2 plus, 3 plus, like that. The actual solution contains potassium dichromate, and that is compared to the serum. And if there is 1 plus, they have the 2.5, like that. Or the chromatographic method for actual measurement of serum bilirubin. So jaundice is defined as the yellowish staining of skin sclera and mucous membrane by bilirubin. This is a yellow-orange bile pigment. And the name comes from Jaune, which is a name for a river in French. So clinically detectable when the serum level of bilirubin goes above 3 milligram per deciliter. So when you see the bilirubin metabolism, it has got a pre-hepatic phase, intrahepatic phase, and a post-hepatic phase. Only around 4 milligram per kilogram per day is the production of bilirubin. So only around 400 milligram to 500 milligram is the daily production of bilirubin in the body. And around 80% results from catabolism of RBC and 20% from other sources, including ineffective erythropoiesis, myoglobins, and cytokines. So how the body handles bilirubin? It is actually produced from rupture of the senescent RBCs. The heme part is taken, and the heme is converted to biliverdin by the heme oxygenase system, and then biliverdin, which is a water-soluble substance, which is converted to bilirubin by biliverdin reductase. And finally, the bilirubin, which is known as the unconjugated bilirubin, it is transported by albumin into the liver, where there is uptake, conjugation, and final excretion into the biliary canaliculi. That is how the bilirubin is handled by the body. So liver plays an important role in the excretion of this bile pigment. So whenever there is some disease process affecting the liver, you can have elevation of the bilirubin. So this is the hepatocyte structure. You can see the hepatocyte has got two sides. One is the sinusoidal PC, OATP, etc. These are all receptors which transports the organic ions, bilirubin, bile salts, drugs, etc. from the liver and into the liver. So whenever there is a change in these receptors, you can have problem in bilirubin handling as well as problem in handling other salts and drugs. So bilirubin, basically there are two types of bilirubin. One is the unconjugated bilirubin, which is water insoluble, but in the normal individual, around 90% of bilirubin is in the unconjugated form, and only less than 10% is conjugated. And it has got a high affinity for lipids. But conjugated bilirubin, being a polar molecule, it has no affinity to the lipid. So there is no risk of kernicterus in conjugated hyperbilirubinemia. And the conjugated bilirubin is excreted through the kidney, and it will give a direct Vandenberg reaction. And if there is a long-standing biliary obstruction, these conjugated bilirubin can form covalent bond with albumin. They are known as the delta bilirubin. So it may not be clear till the albumin is remaining in the system. So even if we have done a drainage procedure, this patient can have jaundice remaining for a long time. So is bilirubin beneficial? If you have a mild to moderate elevation of serum bilirubin, it is said to be beneficial for the human body. It has got a very strong antioxidant effect, and there are many studies done which has shown that it protects against development of cardiovascular disease and cancer. And this study is mainly done in patients with Gilbert syndrome, where there is a congenitally high bilirubin level, and they have a less potential for developing cardiovascular disease. Jaundice can be a symptom as well as a sign, and most of the symptom results from the yellowish coloration of urine, and sign is detected by the physicians or surgeons. So what are the causes of jaundice? The causes can be basically the prehepatic causes like the transfusion reaction, the hemolytic process, or sickle cell anemia, etc. Or it can be due to hepatic causes like hepatitis, drug-induced hepatitis, toxic hepatitis, etc. Or it can be due to post-hepatic causes like biliary stones or inflammation or malignancies. So obstructive jaundice is not because obstructive jaundice is resulting from obstruction to the flow of bile. It can be in the intrahepatic obstruction, or it can be the extrahepatic biliary obstruction. So intrahepatic biliary obstruction is not corrected by surgery. But surgical jaundice, if you see the hereditary xerocytosis where there is increased hemolysis, there is hemolytic jaundice, which can be corrected by doing splenectomy. So it is also a type of surgical jaundice. So it is not synonymous. Obstructive jaundice is not synonymous with surgical jaundice. Basically, jaundice can be divided into choleric jaundice, where there are bile constituents in the urine, including the hepatic type of jaundice and cholestatic type of jaundice. And in choleric type jaundice, there is no bile constituents in urine, and they all represent the prehepatic form of jaundice. So the clinical aspects of jaundice is whenever the bilirubin is more than 2 milligram per deciliter, we call it as jaundice. But clinical jaundice actually occurs when the value goes beyond 3 milligram percentage. With edema and dark skin, the jaundice may be masked, and there is a predilection yellowish pigment. There will be darkening of urine, and the mucosa of the hard palate, especially when you have patients with the hemolytic anemia, we will look at the hard palate for jaundice and soft palate for anemia. And this will give some color, the greenish color to the skin and sclera, especially when there is biliverdin in accumulation in the body. And in patients with obstructive jaundice, either intrahepatic or extrahepatic cholestasis, there will be generalized pruritus. So all colored urine do not represent jaundice. It can be due to a concentrated urine in dehydration, or it may be due to the drugs used by the patient like rifampicin, pyridium, or sometimes it may be a part of porphyria, or maybe due to hemoglobinuria or hematuria. And sometimes you may get dark urine in patients with ochronosis, or when there is metastatic melanoma, where the melanocyte pigment is excreted in urine. But if you see the obstructive jaundice patient, the color is described as tea colored. It will not be yellow color. It will have the color of a black tea or cotton. So whenever you have a suspicion of liver dysfunction, we use tests known as the liver function test. It is actually a panel of biochemical tests, but the actual term liver function test is a misnomer because it involves markers of liver cell damage as well as markers of liver function. It has got an anatomic, physiologic, and pathologic basis. So if you do know the LFT, it may be used for in many clinical applications. It will be used to assess the degree of parenchymal damage, or it may be used to differentiate type of liver disease, or it may be used to judge the prognosis of patients in some of the liver disease, and it is used to evaluate the response to treatment in patients with liver disease. So liver function test can be classified based upon those reflecting injury to the hepatocytes or bile duct, like the aminotransferases, LDH, gamma glutamyl transpeptidase, nuclear 5-nucleotidase, etc. Or it may be indicating the capacity to transport organic anion and clear endogenous and exogenous substance from the circulation. So bilirubin is actually excreted by the liver, and that represents the toxic, the clearance of toxin from the system. So it can be used to, LFT can be used to assess the metabolism of drugs by using the aminopyrin breath test or lidocaine clearances, or even simple urea synthesis represents the metabolic process of the liver. So in patients with severe liver dysfunction, the urea level will be very low because there is no production of urea. And it can contribute to an accurate diagnosis of liver disease, but may not represent the actual liver function, like gamma globulin, IgG level, specific antibody test, which is used in patients with primary biliary cirrhosis or chronic active hepatitis, or other tests which we use for viral hepatitis, etc. They are also included among the liver function tests, but they are not representing the actual functions of liver. So few words about amino transferases. These actually are markers of hepatocyte necrosis. They play a role in the gluconeogenic pathway in the liver. So gluconeogenesis takes place only in the liver. So it plays a role, and it is entirely cytosolic and predominantly seen in liver. So it is a liver-specific enzyme. And AST, if you know, AST is otherwise called the SGOT. It is seen 20% cytosolic and 80% mitochondrial. So AST is expressed in other tissues like liver, heart, skeletal muscle, kidney, brain, pancreas. So many tissues can express AST, but ALT is expressed by the liver cells only. So whenever there is increased ALT, that represents there is hepatocyte damage. So highest level of elevation of transaminases are seen in patients with viral hepatitis, toxic hepatitis, and ischemic hepatitis. And in patients who are having acute bile duct obstruction, there may be sudden rise in transaminases, but it will come back to normal within around 48 to 72 hours. So SGPT, or otherwise called ALT, actually a value of more than 1,000 units may be seen in acute hepatitis. And the elevation of SGPT is more than SGOT in most of the hepatic diseases. But the degree of elevation of enzymes actually denote the extent of hepatocellular damage, and lowering of transaminases actually indicate recovery. But one word of caution, a sudden fall from very high value may indicate poor prognosis. And in patients with alcoholic liver disease, the SGOT value will always be more than SGPT value, and the ratio will be more than 2, because there will be some metabolic issues with the pyridoxal phosphate. So there will be only mild elevation of SGPT in patients with alcoholic liver disease. The other enzyme used is the alkaline phosphatase. It is a marker of obstructive liver disease, and it can be elevated in other conditions, including the bone disease, bone fractures, or it can be increased in patients, pregnant ladies, or in disorders of intestine. It is one of the most sensitive marker of cholestasis. And another one isoenzyme described is seen in patients with some of the cancers, especially hepatocellular carcinoma, that doesn't represent a biliary obstruction. So it's called the Regan isoenzyme, and a normal value of around 40 to 125 international unit is considered normal. So sometimes you may see very low alkaline phosphatase, especially in patients with zinc deficiency, magnesium deficiency, hypophosphatasia, etc. This may be a clue in patients with Wilson disease. When they develop acute liver failure, if the alkaline phosphatase value, it will be very low. And if you did not make a diagnosis of Wilson disease, this may actually give a clue. So gamma GT is predominantly located in the endoplasmic reticulum of the hepatobiliary tract, and it is increased in patients with cholestasis and chronic alcoholism. GGT is used to assess patients with occult alcoholism, where you use GGT along with the mean corpuscular volume. And it is not a specific test for biliary obstruction. It may be increased in other conditions also. 5-nucleotidase is another enzyme which is more specific for obstructive liver disease. And alkaline phosphatase, actually, if there is very high alkaline phosphatase, it can actually interfere with estimation of 5-nucleotidase. So if a patient is having jaundice, elevated bilirubin and elevated alkaline phosphatase, we need not test 5-nucleotidase or gamma GT. But if the patient has normal bilirubin, then if there is elevation, you have to check other enzymes to look for the source of elevated alkaline phosphatase. So these are the normal enzyme pattern. The SGPT value will be in the tune of 10 to 35. SGOT will be less than 35. Alkaline phosphatase 40 to 125, and 5-nucleotidase 2 to 10 international units per liter. So this is the ratio which I was mentioning. In patients with alcoholic hepatitis, hepatitis with cirrhosis, the ratio of SGOT to PT is more than 2. So low SGOT to SGPT ratio indicate acute hepatocellular injury when there is toxic hepatitis, or when patients with cholestatic extrahepatic cholestasis, there will be low SGOT to SGPT ratio. So that ratio is also will also give you a clue to the diagnosis. So the liver disease and transaminases, whenever there is parenchymal liver cell damage, there will be elevated plasma, ALT and AST. In viral hepatitis, again, the plasma ALT and AST increase, but increase in ALT is more than the AST. Whereas in alcoholism, as I mentioned, the ALT-AST ratio is reversed. The other test which we use is the albumin level and total protein. If there is chronic liver dysfunction or obstructive jaundice, when there is decreased liver synthetic function, we will have a very low albumin level. But in patients with chronic liver disease, the total protein may be high, but the albumin globulin ratio will be reversed. So for the acute measure of liver function, we use the coagulation factors. And the coagulation factors, basically, we have the extrinsic pathway and the intrinsic pathway. And usually we do the prothrombin time estimation for assessing the extrinsic pathway. So in patients with hepatic jaundice, when there is liver cell damage, there may not be improvement in prothrombin time by injection of vitamin K. You will require to give some fresh frozen plasma or some cryoprecipitate. So when the patient is having a prolonged prothrombin time, which is not reversed by injection of vitamin K, you have to suspect coexisting chronic liver disease. So these are the different types of viral hepatitis which you can see. So viral hepatitis A, B, C, D, E, etc. So the hepatitis A and E usually will have a milder course. Hepatitis B and C, D, etc. They can go in for chronic hepatitis. So when you have suspicion of hepatitis B virus, you check hepatitis B surface antigen. So it indicates acute infection or persistence of more than 6 months of HBsAg indicate chronic infection. So HBeAg is actually indicative of viral replication. So if you have a patient with HBsAg positivity and HBeAg positivity, they are highly infectious. Anti-HBsAg antibody indicates immunity attained by the patient, and anti-HBeAg antibody indicate resolution of acute infection. So there are many antibodies described in patients with hepatitis B virus disease, which is the topic by itself. And when you have a suspicion of high viral load, you can estimate the hepatitis B virus DNA. So the treatment depends upon the hepatitis B virus DNA load as well as the hepatitis B antigen positivity. So I will come to the lab diagnosis of different jaundice, differential diagnosis. So when you have pre-hepatic jaundice, there will be elevated unconjugated bilirubin. The conjugated bilirubin will be normal. The AST, ALT will be normal. Alkaline phosphatase, GGT, all will be normal, and there will be presence of increased urobilinogen in patients with hemolytic anemia. Whereas in hepatocellular and obstructive jaundice, there will be elevated conjugated bilirubin. There will be elevated AST or ALT in hepatocellular damage. Alkaline phosphatase will be normal, and urine bilirubin will be present, and urobilinogen will be present. Whereas in obstructive jaundice, there will be absence of urobilinogen, and there will be increased alkaline phosphatase and GGT. There are other non-hepatic causes for abnormal LFTs, like albumin may be low in patients with nephrotic syndrome, congestive heart failure, or malnutrition. Alkaline phosphatase may be increased in patients with bone disease, pregnancy, malignancy, or even in advanced stage, you can have elevated alkaline phosphatase. Then AST, you can have elevation in myocardial infarction, myositis, or other IM injection. Bilirubin may be high in patients with hemolysis, sepsis, or ineffective erythropoiesis. Prothrombin time can be elevated by use of anticoagulants, antibiotics, some patients with steatorrhea or pancreatic enzyme malabsorption, etc. So you can have abnormal LFT without actual involvement of liver. So how to approach jaundice? So you look for the elevation of serum bilirubin. Is it isolated elevation of serum bilirubin? If so, is it unconjugated or conjugated fraction which is elevated? So if it is accompanied by other liver test abnormalities, you have to think of either a hepatic jaundice or a cholestatic jaundice. If the disorder is hepatocellular cholestatic, I'll come to it. There will be intrahepatic or extrahepatic cholestasis. So you have to do other tests for diagnosing what exactly is happening in the liver. So you have to take a proper history, and you have to do a proper physical examination. You have to interpret the liver function test and other laboratory tests properly, and you have to order some radiologic tests and procedures for correct diagnosis of the conditions producing jaundice. So there are some important clues which you can get depending upon the duration of jaundice, whether the patient is having an acute event or a chronic event, whether it is a stone disease, whether it is a malignancy, etc. If the patient is having painless jaundice, malignancy is likely. If the patient is having a painful jaundice, benign conditions are likely. Fever indicates some form of infection, either the viral, bacterial, or it may be part of sepsis. Patient with arthralgia, rash, glands, etc. may be having an autoimmune etiology, chronic active hepatitis, etc. Pruritus always indicate obstructive jaundice. Lack of appetite or anorexia indicate either hepatocellular disease or a malignancy. Weight loss you get in malignancy and chronic active hepatitis. And if the color of stool is clay colored, indicate obstructive jaundice. And if there is a family history of hemolytic anemia, it may be an inherited disorder like hereditary spherocytosis or sickle cell disease. If there is a history of transfusion, if there is a history of alcohol abuse and other medications, all these will give you a clue towards the diagnosis of jaundice. So one should know how to clinically evaluate the patient. What are the tests which will help us to come to a differential diagnosis? What are the imaging modality and how to monitor the progress of jaundice? So first step is estimate the serum bilirubin. If it is less than 1 milligram %, you can call it as normal. If it is more than 1 milligram, it is elevated. Second step, if it is elevated, is it unconjugated bilirubin? Then it may be due to hemolytic jaundice, or is it conjugated bilirubin? It can be hepatocellular jaundice or obstructive jaundice. So what are the causes of hemolytic jaundice? It can be due to hemolytic anemia, or it can be due to defective hepatic uptake or decreased conjugation, or it may be seen in patients with neonates with neonatal jaundice. So decreased conjugation can be due to decrease in functioning liver cell mass, especially in cirrhosis or chronic hepatitis, or it may be due to defect in conjugation, especially in patients with the deficiency of the UDP glucuronide transferase enzyme, like Crigler-Najjar type 1 and 2 or Gilbert syndrome, or it may be due to acute deficiency of these enzymes, especially patients with hypothyroidism, drugs, and in breast milk jaundice, there is a substance in the breast milk that actually inhibit the conjugation of bilirubin, or it may be due to defective hepatic uptake of unconjugated bilirubin like sepsis, prolonged fasting, or drugs. So neonatal jaundice, one slide about neonatal jaundice. If this patient has got a physiological neonatal jaundice, it appears after 24 hours. The bilirubin value will be usually less than 5 milligram deciliter. It increases and clinically not detectable after 14 days, and it disappears without much treatment. Whereas pathological neonatal jaundice appears within 24 hours, increased bilirubin will be more than 5 milligram per deciliter per day, and more than 5 milligram per deciliter and the rate of increase will be 0.2 milligram per deciliter per hour. So pathological neonatal jaundice will progress over the course of time, and the jaundice will persist even beyond 14 days. And these patients will need treatment according to the course. So what are the causes of indirect hyperbilirubinemia? It may be due to increased production, as I already mentioned, may be due to impaired hepatic bilirubin uptake or impaired bilirubin conjugation. So the congenital hyperbilirubinemia can be due to deficiency of UDP glucuronide transferase enzyme. Crigler-Najjar 1, type 1, there is complete absence. So this child will develop kernicterus and early death. Whereas type 2, there is a lesser degree of deficiency, and this enzyme can be induced by phenobarbital, and they may get symptomatic improvement on phenobarbital. And Gilbert syndrome is a condition which is a very common condition, and it is due to reduced GGT activity to 20 to 30% of normal. And Dubin-Johnson syndrome is actually due to the conjugation factor deficiency. Conjugation, the protein which takes the unconjugated fraction into the liver, or the Rotor syndrome may be due to the complete absence of the organic anion transport protein, where there is no reuptake of the conjugated bilirubin and there is elevation of conjugated bilirubin. So hyperbilirubinemia can be either unconjugated or conjugated, depending upon whether there is deficiency of the enzymes or whether there is deficiency of the transporter proteins. So the word about Gilbert syndrome, it is a very common condition seen in around 6% to 12%. And there is partial deficiency of UGP glucuronide transferase. And the highest incidence is seen in the Middle East, and lowest incidence is seen in the East Asia. And there is isolated hyperbilirubinemia detected as an incidental finding. And the serum bilirubin value is usually less than 4 milligram per deciliter and mostly unconjugated. And these value may rise around 2 to 3-fold when the patient is fasting, when there is dehydration, or when they have some other illnesses, and may have increased. These patients may have increased incidence of gallstones, and they are prone for toxicity with some of the drug which requires conjugation, like the UDP glucuronide transfer, recurring UDP glucuronide transferase enzyme, especially the irinotecan type of chemotherapeutic agent. But interestingly, these patients are at decreased risk of cardiovascular disease. So this is about unconjugated hyperbilirubinemia. So the next is to look whether it is conjugated bilirubinemia, hyperbilirubinemia, do AST and ALT. If it is elevated, hepatocellular jaundice is likely, then the alkaline phosphatase and 5-nucleotidase, etc. will be normal. If it is not AST, ALT elevation, do alkaline phosphatase and GGT. If it is elevated, indicates obstructive jaundice, where the AST, ALT will be normal or very mild elevation will be there. The fourth step, the hepatocellular jaundice, you have to look for the features and differential diagnosis. There will be elevated conjugated bilirubin, AST and ALT are increased, alkaline phosphatase, 5' etc. are normal. It may be due to the conditions as already mentioned, like hepatitis, toxic hepatitis, malignancy, or cirrhosis. So what are the causes of hepatocellular damage? It can be due to various infections, various toxins, alcohol, drugs, or it may be due to immunological damage or neoplasms or part of other systemic diseases. So differential diagnosis of hepatocellular jaundice can be acute hepatocellular injury like viral hepatitis or alcoholic hepatitis, or it may be chronic hepatocellular injury resulting from primary sclerosing cholangitis or biliary cirrhosis or drugs, or it may be multifactorial like total parenteral nutrition, systemic infection, post-operative infection, may be part of sickle cell disease or crisis, after organ transplantation when it is part of rejection, or it may be seen in miscellaneous conditions like severe hypotension, hypoxemia, congestive failure, Budd-Chiari syndrome, or it may be due to inherited or some of the endocrine conditions, or in pregnancy, or it may be due to infiltrative disorders like amyloidosis or tuberculosis. So the features of viral hepatitis I already mentioned. We have hepatitis A virus, where there is an incubation period of 15 to 45 minutes. So the jaundice preceded by some of the prodromal symptoms actually indicate hepatitis B, A virus. In patients with hepatitis B, C, etc., there may not be some actual prodromal illness detected. So the other conditions like hepatitis B virus, C virus, and D virus infection, they can go in for the carrier stage and chronic hepatitis B. And whenever there is increase in the count of these viruses, they can have acute exacerbation and sudden increase in the bilirubin values. So these are the conditions which result in chronic liver disease, alcoholic or viral hepatitis, autoimmune disorders, inherited disorders, and NASH, which is a very common condition where the jaundice is not the common thing happening. There is elevation of the transaminases and they may progress to cirrhosis. And when they develop cirrhosis, there will be elevated jaundice. So these are the drugs which can produce hepatotoxicity like the acetaminophen, alpha-methyl dopa, or the amiodarone, disulfiram. So many drugs and natural substances are responsible for hepatocyte damage. The next is about cholestasis. Cholestasis is a condition where there is elevated conjugated bilirubin due to impaired bile formation by the hepatocytes or by the impaired bile flow by the bile ducts or bile ductules or both. So it may result in bile acid-induced hepatocyte injury, or it may result in secondary biliary cirrhosis. Patient can have bile acid deficiency in the gut. They are prone for infection, bacterial translocation, etc. There may be fat malabsorption or fat-soluble vitamin malabsorption. So the characteristic of cholestasis include high plasma bilirubin compared to the other type of jaundice. There will be sudden elevation and increased level of conjugated bilirubin. There will be alkaline phosphatase elevation. There will be deficiency of prothrombin, and these patients can have hemorrhage due to malabsorption of vitamin K, and they can have hypercholesterolemia due to decreased clearance of serum cholesterol. So this patient can have pruritus, fatigability, xanthomas, hepatic osteodystrophy, pale stools or steatorrhea. There will be evidence of fat-soluble vitamin deficiency. Liver will be enlarged, firm, smooth, and non-tender with non-tender edge as compared to the viral hepatitis. If you do see the liver biopsy, there will be bile pucks, there will be feathery degeneration of hepatocyte. So the hepatocyte degeneration is happening secondary to the biliary canalicular dilatation and compression. There will be small bile duct destruction, and there will be cholangitis and portal edema. So these are the conditions which result in intrahepatic cholestasis, like viral hepatitis A, B, and C. You will have what is known as the fibrosing cholestatic hepatitis. And in hepatitis A patient or E patient, can have the cholestatic form of hepatitis, where there will be severe pruritus, elevation of bilirubin, but the SGOT-PT value will be returning to normal. It can be seen in patients with alcoholic hepatitis, primary biliary cirrhosis, and so many conditions, including cholestasis of pregnancy and patients taking total parenteral nutrition. So the extrahepatic causes of biliary obstruction, which a surgeon is very interesting to know. The benign conditions include the stone disease or biliary stricture or primary sclerosing cholangitis or chronic pancreatitis producing strictures of bile duct or AIDS cholangiopathy or Merici syndrome or parasitic disease. And malignancies including cholangiocarcinoma, pancreatic cancer, gallbladder cancer, ampullary tumor, or malignant involvement of the porta hepatis liver. All these can result in extrahepatic biliary obstruction. So these are the pictorial representation of the causes of extrahepatic biliary obstruction. It can be a mural or the intrinsic causes, or it can be luminal causes like stone, or it can be extrinsic causes by tumors which infiltrate the bile duct. The few word about pruritus in cholestasis. Pruritus is a very difficult thing to manage, especially in patients with intrahepatic cholestasis. If pruritus occurs in extrahepatic cholestasis, if you do some form of biliary drainage procedure, we can actually ensure relief of pruritus. But if the patient has got intrahepatic cholestasis, it is very difficult to manage. So pruritus is the symptom which is requiring palliation in most of the cholestatic jaundice patients rather than the jaundice per se. So the pathway which results in itch and pain are both same. So whenever there is pruritus, the patient scratches. The scratch is a method of minor pain induction, because when you induce pain, the itch stimuli will be prevented from its action. So the pathogenesis of pruritus can be due to so many conditions. In fact, it is poorly understood, and there are so many pruritogens described like bile salts, progesterone metabolites, or histamine, serotonin, endogenous opioid, gastrin-releasing peptide, or endovanilloids, because all these are utilized for manipulation in patients with pruritus. So it is not seen in all patients with cholestasis. So the bile salt may not be the actual reason for cholestasis in biliary obstruction. There may be poorly understood factors which results in pruritus. So pruritus is more severe in patients with intrahepatic cholestasis than extrahepatic cholestasis. So the treatment of pruritus, when there is a surgical cause, or when there is biliary obstruction, which can be relieved by intervention like endotherapy or percutaneous means, that will relieve relieve the pruritus. But intrahepatic cholestasis, the management of pruritus is very challenging. So there are many drugs used, many methods used in treating pruritus, including ursodeoxycholic acid, cholestyramine resin, rifampicin, then the opioid antagonists like naltrexone, naloxone, serotonin reuptake inhibitor like sertraline, and you have the ondansetron, but these are not showing clear evidence of effectiveness in most of the trial. But also deoxycholic acid and cholestyramine and rifampicin, these are the drugs which show a good response in patients with intrahepatic cholestasis. So UDCA, it renders bile acid pool more hydrophilic, and it improves the impaired hepatobiliary secretion, and it detoxifies bile, and it exerts anti-apoptotic effect on hepatocyte and cholangiocyte. And it is a well-tolerated drug. And in most of the patients with minor form of intrahepatic cholestasis, these patients will get good response to UDCA. The other thing is the anion exchange resin. The commonly used one is the cholestyramine, or other one is the cholecystipol. It prevents reuptake of bile acid in the gut, around a dose of around 4 gram per day, or daily or BD. Or timing is usually 1 hour before or 1 hour after meals. And if a patient is taking drugs like UDCA, digoxin, warfarin, etc., you have to time the use of anion exchange resin such a way that at least 4 hours prior to these medications. The another wonder drug used in the treatment of pruritus is rifampicin because it induces phase 1, 2, 3 transformation of most of these intrahepatic enzymes, including the cytochrome P450 or UGT-A1, or even the MRP2, the canalicular conjugate export protein, that is actually induced by rifampicin. So another interesting thing is alteration of intestinal metabolism of pruritogens by these antimicrobial effects. So rifampicin is another drug. Though rifampicin has got hepatotoxic effect, it is used to treat patients with intrahepatic cholestasis. So this is the step-by-step approach. Sorry for the pure view. This patient with pruritus, when you exclude the primary biliary cirrhosis, primary sclerosing cholangitis, pregnancy, etc., you first give UDCA in a dose of 10 to 20 milligram per day. Then it's not responding, you can add cholestyramine. If it is not responding or poor response within 2 weeks, add rifampicin. Then you can try the naloxone, 25 to 50 milligram per day. Or if not responding, you can add sertraline, 75 milligram per day. And finally, you can try those experimental drugs which are mentioned for treatment of pruritus. The next thing, very important thing, what is the role of imaging in jaundice? In my personal opinion, even if you have a doubt of prehepatic jaundice or hepatic jaundice, a baseline ultrasound is a must, because we may miss so many surgically correctable disease thinking that it is only simple viral hepatitis. So a baseline ultrasound is indicated in most of the patients with jaundice when there is persistence of jaundice beyond 1 week. So ultrasonogram is the first line imaging modality which is considered as an extension of your clinical examination. It will show the presence of intrahepatic biliary dilatation when there is extrahepatic obstruction. So actually, if you do ultrasound, it will help you to plan what is the next investigation in the list. So when this obstruction is in the lower part of bile duct, you can order a CT scan. But when the obstruction is in the upper part, especially in the hilum, you require a CT scan as well as an MRCP. The ERCP is not utilized as a diagnostic tool, but if you have a stone disease, you can use ERCP as a therapeutic method. The endoscopic ultrasound is a very useful investigation in identifying very radiolucent stones or small tumors, and it can be used to take biopsy from pancreatic tumors or the lower bile duct tumors. So when you do ultrasound, it may show dilated bile duct, or it may, so then you can order a CT, MRCP, or a PTC. But if it's showing non-dilated bile duct, the likelihood of intrahepatic cholestasis is high. You have to do the serologic studies like AMA, etc., for the viral hepatitis markers or the chronic active hepatitis markers. You have to look for the drug history, review drug which can cause intrahepatic cholestasis. If everything is negative, you can order an MRCP or liver biopsy. If AMA is showing a positivity, you can do a liver biopsy. So this is the ultrasound which shows intrahepatic biliary radical dilatation with a stone in the lower part of bile duct. Suppose if you have a patient with chronic obstruction or chronic recurrent cholangitis, etc., even if there is obstruction, you may not be able to pick the intrahepatic biliary radical dilatation. The similar is the situation in patients with cirrhosis and in patients with cholelocalcis, because the back pressure change which results in intrahepatic biliary radical dilatation cannot occur. The CT scan is the most commonly used investigation in patients with lower bile duct obstruction, where you can actually see the double duct sign. The middle picture shows dilated pancreatic duct and bile duct. That is the double duct sign which you can get in carcinoma head of pancreas. So this is another interesting CT which I have operated a few months back. Patient had a large mass in the head of pancreas is almost compressing onto the main vascular structure with biliary obstruction. So finally, it turned out to be a serous cystadenoma with biliary obstruction. It's a very rare for serous cystadenoma to produce biliary obstruction, but patient underwent surgery and it cured of her problem. The MRI will show the dilatation of bile duct, intrahepatic stones, the double duct sign I mentioned. In tumors, you can see dilated pancreatic duct and dilated bile duct. The endoscopic ultrasound is a very useful test which will pick up the cause for jaundice, as well as it will help you to stage the tumor, whether there is a vascular invasion, and it will help you to do biopsy from the lesion, as well as in patients with advanced pancreatic cancer, you can use EUS to do what is known as the EUS guided celiac ganglion block. So what is the role of ERCP? You can use it to get biopsy from ampullary lesion. You can take brush cytology from bile duct and pancreatic duct. You can extract stones from the bile duct, and you can stent an obstructed bile duct. So this is the ERCP picture. You can see a stone in the lower part of bile duct, and you can extract it through the ampulla. So these are the various studies which compared different imaging modalities, including ultrasound, CT, MRCP, and most of the studies have shown that abdominal CT and abdominal MRI has got almost the same sensitivity and specificity in picking up the lesions in patients with the extrahepatic biliary obstruction. So how to manage extrahepatic biliary obstruction? You have to manage the patient's obstructive jaundice per se with adequate hydration, antibiotic use, maintain good bowel movements, giving IV fluids. May have to start antibiotic. You have to correct the coagulation abnormalities. You have to give albumin infusion when the albumin value is low. And the definite management of obstruction depends upon the cause. If you have a choledocholithiasis as a cause, you can actually do ERCP, then followed by lap cholecystectomy. Or if there is expertise, you can do lap cholecystectomy and CPD exploration in the same setting, or you can opt for an open chole plus CPD exploration. That was the previous treatment, but nobody uses this treatment nowadays. Or sometimes we may have to do CPD exploration followed by a hepaticojejunostomy or a choledochojejunostomy, especially when this patient is having recurrent stone disease or when the patient is elderly, where repeated procedures will be more dangerous for the patient. So choledocholithiasis can be primary or secondary, and it may be seen in around 20% of patients at the time of cholecystectomy. But if you do MRCP routinely in all patients with choledocholithiasis, the rates may be less. So patient can have asymptomatic choledocholithiasis. Then if there is choledocholithiasis, you can do ERCP stone extraction. So this is the ERCP technique where you cannulate through the ampulla, you extract the stone into the bile duct. You may not retrieve the stone externally, that will be just passed in the stools. The biliary stricture may be seen in some patients after surgery, especially laparoscopic cholecystectomy, where there is a very high incidence of the peripheral surgeons doing cholecystectomy. And if the anatomy is not clear, if the surgeon is not experienced, they can have injury to the bile duct, and this patient can develop jaundice in the post-op period. Initially, they may develop biliary leak, and finally, they will go in for a biliary stricture. So this is one patient I operated day before yesterday. This patient underwent lap cholecystectomy, and you can see the entire area is left off, and now you can see the right and left duct separated, and I did a hepaticojejunostomy. The malignant biliary obstruction can be of various conditions. If there is a carcinoma of the head of pancreas or lower bile duct cancer or ampullary tumor, we will opt for a pancreatoduodenectomy. If there is a tumor of the mid part of common bile duct, we will opt for a excision of the tumor with lymph node dissection and hepaticojejunostomy. If there is a carcinoma of gallbladder with involvement of bile duct, we will do what is known as extended cholecystectomy with excision of bile duct and hepaticojejunostomy. And if there is a hilar cholangiocarcinoma, we will opt for a hepatic resection plus hepaticojejunostomy. So this is one patient who underwent pancreatoduodenectomy, where you remove the distal part of stomach or the duodenum along with bile duct, gallbladder, head of pancreas, uncinate process, and proximal jejunum. And finally, you have to reconstruct pancreatic duct, bile duct, as well as the duodenum. So this is a very complicated procedure. It is prone for complications in the form of pancreatic leak and around 5 to 10% mortality even in high volume centers. This is the second thing, which is the hilar cholangiocarcinoma. The patient, you can see the right and left hepatic duct separated, where the intraoperative image shows a tumor at the hilum, and which is resected. And finally, you can see the the right lobe of liver, which is left, and you have to make an anastomosis with the divided duct on that side. That's a hepaticojejunostomy. So the diagnostic approach, in a nutshell, you have to consider the history like abdominal pain, fever, etc. You have to consider all the laboratory tests I have mentioned and the physical examination. So this is the algorithm for evaluating patients, evaluating and managing patients with elevated liver function tests, depending upon whether you have elevated alkaline phosphatase or elevated aminotransferases, and you will plan the investigations and you will plan treatment accordingly. And there are some special situations like jaundice in pregnancy. I won't go into the detail. It may accompany patients with hyperemesis gravidarum, but it is self-limited and it will come back to normal. But intrahepatic cholestasis of pregnancy typically occurs in the third trimester, may present with pruritus and occasional jaundice. It generally resolves within 2 weeks of delivery and often occurs with subsequent pregnancy. So if a patient has got intrahepatic cholestasis of pregnancy, there is a chance that they may develop recurrence in the subsequent pregnancy. But there is a very dangerous condition. It's known as the acute fatty liver of pregnancy, where there is the acute liver hepatocellular injury occurring in the third trimester. Jaundice may be accompanied by features of liver failure, may be fatal, and sometimes it may require emergency liver transplantation. The another situation where you can get jaundice is a critically ill patient. It may not be due to the liver disease per se. It is a very great challenge for the intensivist or the consultants who are in care of this patient. The predisposing factors may be hepatic ischemia or blood transfusion or hepatotoxic drug, or maybe due to TPN or occult sepsis. The renal injury may reduce elimination of conjugated bilirubin. It can itself cause increase in the bilirubin. So there may have been a lag in the resolution of jaundice even after improvement of other parameters. So once the jaundice is not recovering, we have a tendency to order for a ERCP or other biliary drainage procedure, but that may not be required in most of the cases. So you have to be very patient and you have to search for reversible causes in patients with jaundice in critically ill. The last one is about postoperative jaundice. Whenever a patient develops jaundice in the postoperative period, it is seen in around 17%. You may have to exclude the drug toxicity like anesthetic gases, sepsis, presence of choledocholithiasis, pancreatitis, or biliary injury, which might happen during the surgery for a non-hepatobiliary surgery. There is a condition called benign postoperative cholestatic jaundice. It can occur anywhere between day 1 to day 10, but most of the time it will spontaneously recover. So with this, I think I will come to the end of my talk. And this is the gooseberry, which has got some effect on jaundice as per the traditional Ayurveda. So I'm happy to take any questions. Thank you for your patient hearing.